this evening. Dr. Kirkpatrick, in addition to being a long-standing mentor of mine for, I'm not sure, we've lost count, 15 to 20 years, somewhere in that order. He is also he is currently a professor of medicine and bioethics, and the section chief of cardiac imaging in the Division of Cardiology, as well as director of the Echo Lab at the University of Washington Medical Center. He sees patients in the general cardiology and aortopathy clinics. He's one of the few ethics-trained cardiologists in the US, and he's actually the chair of the University of Washington Medical Center Ethics Committee and serves as a clinical ethics consultant. He lectures and performs research in the areas of cardiac devices, palliative cardiology, and echocardiography. He has held multiple leadership positions in cardiovascular societies, in cardiovascular genetics, and in cardioethics. He graduated from Pomona College and received his MD from Loma Linda University. And he did his internship and residency at Yale in internal medicine. And then he went on to do a clinical medical ethics fellowship, as well as cardiology fellowship at the University of Chicago. He was on the cardiovascular and ethics faculty and co-chaired the ethics committee at the University of Pennsylvania, which is where I was lucky enough to meet him and benefit from his incredible mentorship. And then he joined the UW Cardiology and Bioethics and Humanities in 2015. His personal interests include reading, history, and travel, especially with overseas medical outreach. So without further ado, I present you Dr. Jim Kirkpatrick.
Thank you so much, Sarah. I really, really appreciate it. It is wonderful to be back in this room 22 years later, since I was last in the upper row falling asleep during medicine grand rounds on more occasions than I would like to admit, unfortunately. But it is truly a pleasure and truly an honor. I'm hoping to address this issue of cardioethics, or what we like to call cardioethics, and how I think it needs to be part of all of our toolbox, if you will. We have many tools, but this, I think, is one of them. As Sarah mentioned, I am currently at the University of Washington in Seattle. It is truly a beautiful place. We have fountains, we have lakes off in the distance. But I do feel that I must dispel some things. First of all, it's the University of Washington, not George Washington University, Washington and Lee University, or Washington University in St. Louis. None of those are true. This obviously is a sore point for me and many of us who are from Seattle. I should also point out that we are the Huskies, but we are not UConn either. And I will bet you that UConn does not have the opportunity to do an echo on Harry the Husky, the way that our stenographer, Jamie Sheehan, was one of our excellent stenographers, has been able to do. University of Washington is located in Seattle. We are famous for a number of different things. And one of the things that you should realize, it actually rains more in Miami than it does in Seattle. It's just kind of this constant gray drizzle for 9 months out of the year. And the other thing that most people don't realize is the Space Needle is actually not the tallest building in Seattle. It's many of these other buildings that you can see. Seattle is a truly beautiful place. We've got lakes, we've got mountains, we've got just amazing and beautiful vistas, but we also have Pike Place Market. And at Pike Place Market, we love to throw fish. It is something that you have to see. It's kind of one of those things when you come to Seattle. I don't think these guys are still there necessarily, but watch out if you do go there, because you might be hit. Additional disclosures besides the fact of my background are that I, as an ethicist, I personally think that one should probably avoid relations with industry. I do get some salary support for some studies, including a bioethics supplement for the NIDDK. So our objectives and outline for today, I'm hoping that I can answer this question: why should we add ethics to our toolbox? And I have a case that will hopefully illustrate that. I want to address this issue of ironic technologies and the technological imperative. As Sarah mentioned, this is kind of a personal interest of mine. And I want to kind of end, and I have a little trepidation about talking about empathy here at Yale, because there's such a long and storied tradition that I benefited greatly from when I was here. But I'm hoping to do it a little bit of justice, and I put empathy in quotes for a reason that you will see, and hopefully will be illustrated. Cardiovascular medicine is blessed with rapid advances in technology. As you know, the randomized controlled trial, double-blinded hopefully, is our holy grail of evidence. We are fortunate to have both improvements in longevity and quality of life. We don't often have to choose between the two of those, which is not true for everybody. We're obviously very well funded. But sometimes all of this leads us to the situation in which scientific advances can outpace ethical discourse. Some may feel that that's entirely appropriate. The fact that we are number one in age-adjusted death rates means that we're extremely important, but I would argue that that makes it more important to have ethical discourse on it. Now, this is really old data, I admit, and this has changed dramatically, but I just mention it to say that we probably still have this reputation. We sometimes have difficulty in interacting with terminally ill patients because our patients never die, right? I mean, as long as we have them on GDMT and put enough devices in them, they will live forever. Traditionally, we've had trouble with withholding things from patients. Our sort of paternalistic view may have been a little bit more so than others in the field of medicine. We sort of, when asked about prognosis, we tend to be a little bit rosier, maybe than our patients and those about others. See point number one. And at least traditionally, we have been known to initiate CPR and ventilation for patients with severe chronic diseases and marginal prognosis, at least more so than our colleagues in other specialties, especially maybe ethics. And that leads us to perhaps different views of cardiology and ethics. This idea that ethics being very low tech and humanistic focused, difficult to study. I can give that as a personal testimony. Quality of life is the focus. Inexpensive, certainly, ethicists are cheap. And we talk about things like good death. Whereas in cardiology, very high tech, very mechanistic, mechanical, data-driven interventions, life prolongation. We cost the system a whole lot of money. And maybe our ethos, rather than good death, is more of a, well, let's just give the patient a chance. Let's go ahead and try things. And so we may see these as the older versus the modern toolboxes or different crafts. But I think really what we can do is bring these together. We can merge these toolboxes. And this is what cardioethics is. This is a paper that Sarah first authored that came out in JACC Advances very recently. And this laid out the case. And I love the way that she really did direct this idea of practical ethics brought to divisive challenges in contemporary cardiology. Why is it relevant and how can we make it more so? And part of this was really seeing the different domains that ethics has commentary on within cardiology. I've put little hearts next to the ones that I think are particularly important, but I think it was very important to divide this into professional ethics, where Sarah lives, more so clinical ethics, where I spend more time in, and then system and organizational ethics, which all of us live in, to be honest. And the different things that are particularly unique about cardiology, I think, as opposed to other subspecialties. I'm not going to read all of these, but really these are the things that really touch our lives all of the time. A paper that we have coming out very soon has actually proposed a cardioethics curriculum to be used in cardiology fellowship training and other instances of training cardiovascular professionals. We focused on just these issues here that you can see up there: heart transplant, futility, distributive justice and fairness, and withdrawing of life-sustaining treatments. But as I've already said, there's so many more areas that hopefully this will begin to influence the dialogue at least cardiology fellowship training level. Well, let me illustrate some of this. Sorry, this but this is the storm's aftermath. This is a published case by one of our trainees, Jill Steiner. It starts with a 63-year-old man with stage D heart failure, ischemic cardiomyopathy, was transferred from an outside hospital in VT Storm. He'd already received multiple shocks and fortunately or unfortunately never syncopized during any of them. And interestingly, he had just before that been discharged on home inotropes. So back up, 8 months prior, he had had a cardiac arrest with an anterior STEMI, had an LAD stent, 2 weeks ICU stay, obviously didn't do so well, and was home after 3 weeks after presentation. 3 weeks after that, he had an end STEMI. No revascularization was performed at that time, but he had another prolonged hospitalization with multiple arrests, strokes, UTIs, Klebsiella pneumonia, respiratory failure, got trached. And this time it was 8 weeks in the hospital before he got home. 1 week after that discharge, another NSTEMI brought him back in. This time they attempted to PCI his 100% proximal LAD and then gave up and transferred him to us. And he was on the consideration for advanced heart failure therapy, but was turned down for VAD due to frailty and debilitation and other issues. He had a slow inotrope and pressure wean. He was unable to tolerate optimal medical therapy. But at that point, he had a secondary prevention ICD placed and went home after 5 weeks. And it was interesting because again, he had another one again, no intervention, home after 3 days at this point. Now, when asked about this, he really did not have a good understanding of what occurred during the first 3 hospitalizations, despite the fact that this was explained to him several times with a translator who was non-English speaking, had impaired vision and speech. It had prior strokes in the past, so actually it was a little bit difficult to understand what was going on. But he had communicated that he wanted an ICD. The family was strongly in favor of an ICD, and that's why it was implanted. Now, 4 weeks after the last discharge, he came in cardiogenic shock. He had a new mural thrombus found on echo, and again, had arrest criteria, this time aborted with ICD shocks. Continued to deteriorate, lost decision-making capacity, and now we're talking to the family. The family agreed to DNR status in the face of what was explained to them as medical futility, but they did not want to deactivate the ICD. Ultimately, he endured 41 ICD shocks over a few-week period. Every time he was shocked, it was very uncomfortable for both the patient and very distressing to the family and the care team members, the nurses in particular. And the family was very approving of symptom management with medications to try to make him comfortable, but they still did not want to deactivate the ICD. The discussion was had about replacing the ICD because now it was running out of battery, and it was explained that we were not going to do that, and they ultimately agreed. And the patient passed away, ironically, due to an asystolic cardiac arrest. This was a very distressing case for a lot of people. And it brought up for us this idea of ironic technologies and something that has been termed the technological imperative, which you may or may not have heard of before. This is from an article that was by Kaufman and also a good friend of mine who has worked in this field, thinking about what the meaning of devices actually are and labeling, and they in particular were looking at ICDs in this case and labeling it as an ironic technology. Ironic because it does multiple things at the same time. It's sort of intended to extend life, and other technologies obviously to improve quality of life, but they do other things at the same time. They shift goals sometimes. They present new challenges. They may even prolong the dying process, as some would argue happened in this particular case. And they bring up this technological imperative, but also along with it, I would argue there's kind of becomes the kind of a moral imperative. This idea that because we can, we should do it. The technological imperative has been defined in a lot of different ways. This is from PSA Magazine, the concept that new technologies are inevitable and essential, and that they must be developed and accepted for the good of society, or perhaps for the good of the patient. And this philosophy is naturally promoted by high-tech companies. That's understandable. But it really does create some issues here as well, as we've illustrated. Technological imperative also has sort of been thought of as the need or the imperative to develop new skills and tools. And obviously that creates pressure then to use the things that we have. Other people might say, and this is a more general term, of course, but we can, therefore we must, sort of from a moral standpoint. And technology tends to displace persons as the focus of interest and create confusion about the purpose and limits of restorative healthcare. I think that it sort of encapsulates some of the issues that we face with this. Now, in cardiology in particular, we have a lot of tools. We have a lot of toys, and there is this pressure to use them. But then that creates a lot of issues, like what are we going to do with that VAD when the patient is otherwise dying? What are we going to do with ECMO? Defibrillator deactivation, as we've already discussed. What about changing out a CRT-D battery? What about initiating renal replacement therapy? High-risk surgeries kind of fall into this category. Heroic percutaneous interventions, be they on the coronaries or on the valves. How about an Impella? What about inotropes? All of these things challenge us, and a lot of them are based on our conception of what these devices are or what these things are and exactly what they do. So this was put together by Dan Sulmacy and talking about pacemakers, and particularly he was trying to explain how it is that it was ethically permissible to deactivate them. And the problem was you have an implanted device here, it actually maintains life. Can you actually deactivate it? And he said, well, there's a difference between a regulative thing and a constitutional therapy. Regulative will coax the body back towards homeostatic equilibrium. And it might have some of these other green box things, like it's intermittent, it's outside, it's not part of the self, it doesn't have any biologic properties in terms of repairing or responding and things like that. Whereas the constitutive therapy can be substitutive or replacement, but it really takes over a function that the body cannot provide for itself. So this might be continuous and inside itself, and it might have some biologic properties and independent of energy sources and that sort of thing. So you sort of have your classic implanted device versus, say, a transplanted heart that is really quite different. So how are you going to actually think about this device would actually determine whether what you're going to think about its deactivation or continuation per se. Now, I think we also need to recognize that there is some ethical conclusions about this. And as you hopefully know, one of your own faculty here, Rachel, has done an amazing job in setting this entire field. And I think this 2010 HRS consensus statement stands as one of the hallmark articles that has helped define this field and helps us think about this very carefully. And they said a few things in here which have stood the test of time. One is that CIED therapy is requesting withdrawal is no different between refusing it to begin with. So withdrawal and withholding, really ethically the same thing. Ethically, CIED deactivation is not physician-assisted suicide. That's now an older term, but it's the same sort of thing, nor is it euthanasia. And it's an important distinction for those who have issues with those two things in particular. And finally, that no treatment inclusive of CIED therapies has any sort of unique ethical or legal standard. These are all very, very important bedrock understandings of how we're going to approach devices at the end of life. Now, even though I think this reflects most people's view of it, and there's still some controversy about this that I won't go into, there are still some interesting issues that come up that we have to challenge ourselves with. So for instance, this came up in our case. Shouldn't we just turn the thing off, even over the family's objections? And presumably if the patient would have been able to say something, because the patient said this before, but over the patient's objections. There are some other reasons to think about this besides patient suffering and suffering of the staff. There's cost consciousness, person sitting in the ICU, it's a scarce resource, and then just kind of our understanding of futility and inappropriateness. And we do this all the time. We make unilateral DNR, for instance, this is pretty much standard. If there's different ways that hospitals deal with this and different protocols for it, but that's pretty much a thing. But is this, the deactivation unilaterally of an implanted device, a different entity? Well, we actually were very interested in that. So we asked both patients and electrophysiology providers this question. And it turned out that about the same percentages in both groups thought that this was not appropriate, even in the setting of futility. There was about the same unsure or no answer, and then there were some that really did think the device should be turned off if two physicians agree that this is a futile situation. Now, we don't know, we didn't ask them why, and I really wish we had, but part of the reason might have been that this could actually be construed as battery. You know, assault is sort of a verbal assault on someone, but battery is actually hitting someone, unlawful, unwanted touching. If you put a programmer over a device, touch the skin, could you actually be committing battery by unilaterally turning off the device, unwanted touching, unauthorized assault and battery on this particular patient? Well, if that's the case, what do you do about remote deactivation? Is that the same thing? So this has never been tested in the courts. To my knowledge, this really is no even case studies are available for this, but these devices create these very interesting dilemmas that we have to deal with. They are ironic technologies. Now, there's another somewhat ironic technology. I just want to highlight this. I had some very interesting conversations over the years about this. We got funded from the ACC and the geriatric section to investigate this issue of peri-procedural DNR in the TAVR program, in TAVR programs. And so what we did is we actually interviewed TAVR program coordinators from Washington State and from California, who are registered basically with the ACC. We reached out to them, we contacted them, we said, asked, would you allow us to do this? Some of them said, well, my program won't allow me to talk to you about this. Others of them said some very interesting things. There was one that was across the street from a nursing home. That was really interesting. But it really kind of highlighted the issues that were in there with this older population who actually might have a DNR. Well, what do you do about that? And we actually found some very interesting things. We got a bunch of press on this too, which is kind of interesting. And the bottom part here was sort of the bottom line was that there were some pretty inconsistent policies. There were a lot of different things that went on there. And this is just sort of our thing. Now, one of the things we realized is there's a difference between practice and policy. So you may not have a formal policy, but you might just do this all the time in your practice. And there are actually probably some good reasons for not having a policy, but doing something nonetheless that's appropriate. So you can see here, there's programs that actually took referrals for TAVR, and then some that basically, if you're DNR, don't even call, where you're off the table at that point. And then there was sort of a different group within that first group there, who actually sort of had consistent practices of maintaining the DNR. Those were the minority, as you can see. And then there were ones that really weren't able to identify either a policy or a practice. And then there are the ones that temporarily rescinded DNR. And we wanted to know for how long. So was it within 48 hours that you put the DNR back on? Or did you do it during the entire hospitalization? Or did you do it 30 days after procedure? And some of them were very honest. They said it's 30 days because we don't want that death on our record. That's why we're doing 30 days. And it was a very interesting thing. We also sort of broke this down by mid and large size and small programs, urban, suburban, rural, teaching versus non-teaching. There wasn't a lot of things to be made of that. They were kind of all over the map for each of these different things. Now, you might actually say that this is just Washington State. We're kind of weird up there. California is really weird, Wild West, and that sort of thing. But interestingly, I think this is probably true for many things. And there is no national standard within cardiology. The anesthesiologists have actually some guidance about that. And interestingly, it's the same thing that you do here as practice and the thing that we actually have as a policy. And that is, you need to have a discussion. You need to elicit the patient's goals and preferences in regards to TAVR and DNR and figure out what the best thing is to do. And you can then decide which way you're going to go with this. Now, I think it's actually important to recognize that most people, when you have this thoughtful discussion, will actually say, I have no problem rescinding the DNR. That's fine, because I understand that it's going to be a quick recovery, one shock, maybe, meds or whatever, and we'll bring it back. And what I'm really concerned about is being a vegetable. I do not want that. But unless you have that discussion, you don't know that. And you have to ask the question, why? I also think that this is really part of this larger issue of empathy. We need to begin to understand our patients. We need to do what we can in that. Now, as you're probably aware, Howard Spiro, who started the GI program here back in the 50s, was a major, major figure in empathy. This is an article that's super important. I would recommend everybody to read this. And some of the things he said there, empathy is almost magical emotion, that persons or objects arouse in us as projections of our feelings. Conversations about experiences and human stories help us to cherish empathy and retain their passion. Now, why is it that I think we need especially to have empathy in cardiology? Is for the reasons that we've already discussed. We have some reputational issues. And we live in a world that isn't necessarily promoting empathy as much as it probably should. Now, empathy implies understanding, and it requires assumptions. But can we really understand our patients? And if we try to, we're probably going to be introducing our own biases into this, especially the bias that we can understand what they're going through or what they're feeling. It also implies sharing, but can we really enter into a patient's situation? Can we really walk in that patient's shoes? Let me move on to the second case, which sort of identifies or hopefully highlights this idea of stories that need to be part of our toolbox. 47-year-old male presents with intermittent nighttime fevers and exertional dyspnea. Fevers had begun 1.5 months prior. Person did not seek medical attention at all, and then developed gradual onset of dyspnea over 2 weeks, couldn't run or keep up with his wife on running. Otherwise, the review system's completely, no B symptoms, no cough, nothing else going on. This person had complex congenital heart disease, repaired at age 16 months, VSD, ASD, and PDA repairs, residual coarct, but it wasn't that significant, and a bicuspid aortic valve. And it had, and been watching an enlarged aortic sinus segment, but then ended up with a David 5 procedure 6 years prior to this presentation. So here's the labs, basically significant for a mildly elevated white count, mildly elevated ESR, and an elevated CRP. Otherwise, everything was completely normal. Blood cultures eventually grew out strep milleri. And as you know, I'm an echo lab director, so I can't possibly give any sort of talk without showing some beautiful pictures. You'll see this. Everybody can recognize that there's a vegetation on the inferior or posterior aspect of the bicuspid aortic valve. You can see the AR there. These are courtesy of my colleague, Eric Krieger, who's an incredibly talented TEER. I can point out here on the biplane imaging, there's a beautiful little hole that you just see so nicely there on the short axis view on the right-hand side. And here's the 3D of the hole. This is from the left ventricular aspect on the left-hand side of the screen, and the aortic aspect on the other. And the reason I show all this is because here's the specimen at surgery. I mean, look at that. It's just exactly, the surgery happened like 2 months later. It's a beautiful picture. This is what we can do with TE. But you already knew that. I'm sure Bob has well educated you on all of those things. But I just fell into the technological imperative, didn't I? I'm focusing on a beautiful echo pictures. I'm just totally doing that. What did I actually leave out in this presentation? I've showed you beautiful pictures, but what I didn't tell you, and what is kind of important for all this, as I'm sure everybody's recognized, is the social history, right? So which one of these do you think is most consistent with the patient's social history? Is this an undomiciled, unemployed, 1 to 2 week use of marijuana patient who denies IVDU? Is this a person who's married, parent of 2, carpenter, daily IV heroin use? Is this married, parent of 3, less than 1 glass of wine per month on average, denies IVDU? Or is this an undomiciled, unemployed, but someone who's been clean and sober from methamphetamine, which is a huge problem in the Pacific Northwest, by the way, for the past 15 years? This determines how we think about this patient, right? Some people would even say, I mean, clearly there's indication for aortic valve replacement, right? But as you're probably aware, and Sarah's written on this, what do we do with someone who keeps coming back after IV drug use, who keeps getting endocarditis again and again and again? How many valve replacements? How long should a valve actually last in these cases? Is this worthwhile, or is it futile to keep putting things in people who abuse themselves? Well, as you probably realize, this obviously, to make the point, is C. So it's the person who you would not suspect of having IVDU. And then of course, this is me. So I have to tell you that I get a lot of, when I mention this, I get a lot of this, you can empathize with your patients now, how wonderful. And it is true. I can totally empathize with sternotomy pain, especially when you have a postnasal drip and you're coughing all the time. It's awful. I can definitely sympathize with that sickening feeling of your edema distended tissues receiving IV heparin. That is the worst. It's worse than the sternotomy pain, actually. It got me out of bed really fast, though, which is very helpful. I can completely sympathize with the fact that you have to give yourself weeks of IV antibiotics. That is definitely not easy to do. I actually had help, and my son, who's sitting over here, is of course now mortified that I'm showing him as he was helping along with his sister and his brother giving me my antibiotics. But there are so many things that I cannot empathize with my patients. I am not unfamiliar with the healthcare setting. When I was in the ICU, that was like my second home. I was on the other side of the bed, but it was still not an unfamiliar setting. I knew so much about what things would happen. This was not an issue of the unknown for me. I didn't have to face that. It's really, really different. I am a Christian. I can tell you how important it was for me to think about, well, if I don't make it, may not be so bad, the afterlife. People who don't believe that, I can't empathize with understanding that. I knew my kids would be okay. So empathy implies understanding, requires assumptions, probably can't fully understand, but is it more about trying to understand? Is that enough as we enter in with our patients? Same thing with sharing. Is it actually creating space for our patients to share with us? Maybe it is, maybe it is not. But given that, maybe we shouldn't be using the term empathy because it implies more than we can do. Maybe we should be talking about compassion. Maybe we should be talking about empathic concern. Well, how do we actually develop that? And maybe this is feeling without understanding. How do we develop that? Well, I think there are some empathy tools, and I'm hoping to sort of equip people a little bit with here. You'll recognize the name Tom Duffy. Tom died recently. It's a tremendous loss. I count him as one of my main mentors throughout my medical career. I had the pleasure of writing this article with him after I got done with residency here and went on to ethics fellowship. I was really struck under his inspiration with this idea that we needed to bring empathy more into our daily rounding. We needed to actually do what we can. So we call this well-rounded, little planned words. But one of the several things that we did in this article was to collect together ways to bring humanism into the inpatient setting. One of the things I learned in medical school was to ask patients, what are you famous for? And now I make all of my house staff do this when we're on rounds. And I can't express to you how many eye rolls that I get when I say this, but I make them do it anyway. And the reason I do that is because patients will say, well, I'm not famous for anything. Now, some of them actually are famous for things. I took care of a very well-known basketball player, actually. I didn't even have to ask him that question. But what it does do is it makes people think about some unique or interesting thing about themselves. So they're not just the fourth patient with congestive heart failure on the surface. They're not just the third person we've seen with atrial fibrillation today. They're actually a grandmother who takes pride in her cooking. They're actually a 98-year-old who actually went skydiving yesterday, and now is in with whatever. It brings the person alive. And I got to tell you, as an attending is the best thing ever, because that's what I lead with. Oh, I hear that you are, the person who actually survived a Nazi concentration camp. This is wonderful stuff. And you should see the eyes light up when this actually happens. It's amazing. I also make them try, and I admit to them, this is so hard, I don't expect you to do it. And of course, that sets the standard, and they're all competitive, and they want to be able to do this. Give your presentations. We go into the room. We don't present in the hallway unless, there's some good reason not to. We go into the room. You need to present to me in front of the patients, and if you can, do it in patient language, because then the patient actually gets to interact with us. They get to understand what we're talking about. And I'm sure you've all seen this. You hear the presentation in medical speak outside, then you go in there, and then they translate it. So they just spent like 5 minutes telling you this, and they translate the whole thing within 10 seconds. And the patient is sitting there going, I know that you said more than that, but they didn't understand it. It is hard, but it's possible. And finally, I think we need to immerse ourselves more in the medical humanities literature. Why? Because literature allows the reader, us, to become an innocent spectator on aspects of living and dying that are not part of our own personal experience. This is how we understand better or approach empathy. The literature enhances our ability to engage in empathy, fuels our curiosity, and we don't even have to get pricked in order to do that. Literature gives us expression to the unspoken and trains us to examine the depths of thoughts and feelings. Now, these are just a few of the books. There's so much more, and this is just, my apologies, this is just sort of doctor-centric, but there are so many things. I would highly recommend Aerosmith. Aerosmith is not the band. That's A-E-R-O. This is Martin Aerosmith, the protagonist in Sinclair Lewis's 1926 novel. When I read this during residency, I was shocked how little medicine had changed. We have the same biases, we have the same ways of looking at life that Sinclair Lewis was able to overcome. You've recognized so many of these other different things. And of course, Sherwin Nuland, who is a surgeon here at Yale, a giant in the field of medical humanities, most known for his How We Die book, won a lot of awards, but he also wrote The Soul of Medicine, which is really chronicling his experience and the things he went through and the patient stories. If you're more interested in it, you have a wonderful humanities department here, and that's the website. And I would recommend, this is from On Being a Doctor. Michael Combs, actually a cardiologist in Maine, and he collected a number of these different stories. I love this one by Dr. Jones, The Chicken Man. I hand this out on rounds all the time. I give it out to the people. I see more eyes roll, but they read it. And this is a beautiful description from a patient perspective, what it's like to have congestive heart failure and not care at all about what your doctors are saying because you don't understand. Highly recommend it. So to wrap up here, I'm going to give you a bunch of quotes rather than some bullet points. This is from something we published in The Lancet a few years ago. Cardiovascular care is increasingly complicated and requires striking a balance between quality of life and longevity, high-tech interventions and supportive care, and unexpected but mercifully sudden death and a prolonged but predictable disease course. And of course, there are things in between that as well, but that's how patients experience a lot of what we do. The modern cardiovascular specialist must understand and explain each of these spectra, considering the individual patient's wishes and best interests, the maleficence of side effects, and the impact of therapeutic interventions in the larger social context. The nuanced approach requires skill in this art of medicine, and I would argue compassion or compassionate understanding at least. And cardiovascular clinicians don't have to become ethicists to practice good medicine, but alerting our collective consciousness to ethical dynamics and equipping trainees, which Sarah is doing so wonderfully here and really expanding that all over the country, with the tools of ethical reasoning will position cardiovascular specialists to address the increasing complexity of our specialty. I think we have the opportunity to do this. I'm very grateful to be involved with Sarah and others who are actually bringing this all to fruition. And I am most of all grateful for all the tools that I got while I was a resident here, which I think will live on through all of our ways that we can actually treat patients. So thank you so much for your attention. I'm happy to take any questions, but thanks for the opportunity.
Thank you so much, Jim. I'm going to go around the room if anyone has questions.
First of all, Jim, thank you so much for spending the time with us and bringing your son along and sharing with us through the day and this wonderful lecture. I want to kind of push you a little bit to give us your thoughts on how cardiologists particularly, but all physicians will have to work through this toolbox to address the challenges that AI brings to medicine. And I'm just, we're doing so much, there's so much potential, but I've just recognized this morning when I was reading the paper that there were more articles on what was happening to Sam Altman in the New York Times on the front page than what was going on in multiple wars across the world. And I just thought, gosh, what's going on here? So I'm just curious what your thoughts are and how we're going to handle that challenge.
Yeah, I think that there's global challenges that AI presents to the entire world, and it's not necessarily creating an environment in which the machines are going to take over and wipe us out necessarily. But the things that are happening in cardiology, and I think in medicine in general, are ones that we need to think about. And I'll sort of cone down a little bit into imaging, because obviously that's what I tend to understand a little bit more. And then I'll make one other comment about that. So from an imaging standpoint, I think we're all worried that the machines are going to start reading our echoes, and they're going to start performing our echoes, and there will be nothing left for us to do if we're imagers or echocardiographers. And I don't think that's the case. I think that we can see these as tools. I liken it to this idea of how we do EKGs, right? And the reality is most of the time that computer-generated interpretation of the EKG is right. But we still are always going to be signing off on it. And I think that will also be the case. It will be able to make measurements, it'll be able to even generate a preliminary report, but we're going to be in a good position to actually be the overseers, much like we do with fellows right now. When the fellow does the pre-read or sonographers do the pre-read. So I think that if we view it as that tool and not sort of as a replacement, we're going to be able to coexist with it a lot better. That said, part of what all AI systems do is reflect the biases of their creators. And while that may not be such a problem in something like imaging, it is a huge problem when it comes to generating prognoses. So if one takes an echo and the AI reads it and generates a list of prognoses for the patient, the technological imperative mindset that many of us fall into, myself included, is, well, the machine said it, it must be right. And so therefore you're going to die, and why would we spend a tab on you? Or you're going to actually do fine, so you don't need to worry about it. There's real danger in that. But the even more dangerous part is when we take all those prognoses. Let's say we take the entire medical record, run it through AI, and the AI gives us out a prognosis. Well, guess what? That AI has probably used the patient's race, the patient's disability status, and all of these other things that will then generate a prognosis. And the danger is that we will lead to incredible systemic inequalities and justice based on our view of technology, which must be right to do that. This is even happening in, just to jump fields a bit, happening in predictive models that say when you need a palliative care consult, right? So yeah, oh boy, you're in trouble. You need a palliative care consult. You better come in here. Well, that can potentially start a whole rock rolling down the hill that is totally inappropriate. Can we fix this by being careful of how these things are designed and how we're actually going to be cognizant of this? Maybe, maybe not. But the problem is not so much the known bias, it's the unknown, unintentional bias, I think.
Thank you. I'm so sorry. If I could add to that, because there's a lot of interest in this at the medical school and our program for biomedical ethics there. I think that this idea of the technological imperative is very salient here. And I think it's a natural cognitive bias to think, oh, well, because, the machine is probably going to be very precise. It's often, although not always, you feed it the same information, it has an algorithm, it will, give reasonably precise outputs. But, there's the question of precision, and then there's the question of accuracy. So just because it's very precise does not mean it's very accurate. And again, the issue with biased inputs is an issue. I think another issue that we come up with is that, as you very nicely outlined, the practice of medicine is not just a technological one, but a moral one. And machines don't have moral agency like people do. And I think that's less of an issue with interpretive AI, but will be an issue with using generative AI as more and more people are talking about. And I think keeping in mind that it's not a substitute or a replacement. It's an extra tool to check your reasoning, to check things with. And then finally, I think often along with the technological imperative is always this idea that, oh, great, this is a technology that's going to make things so much more efficient for us. So we're going to have so much more free time. But I think if we look at, the recent arc of history, technological advancements haven't necessarily made us feel like we have more leisure time or more time to think. It's just completely changed expectations as to how quickly we get things done. And so I think if anything, we probably have less time to sort of think about things and mull things over, because there's just an expectation. Well, I shot someone an email, like, why didn't they respond in 3 hours? And that just wasn't the reality even 20 years ago, I think. So just, keeping expectations versus reality, there's often a large gap there. I think there was a question on the chat from Ed Tui. So do you want to go ahead? Can we?
Yeah, hey, how you doing,
Oh,
Jim?
great.
Can you guys hear me?
Yes.
Hey, I'm so sorry I couldn't make it up. I got diverted to Milford on the way up from Bridgeport for a possible MI. But I thought that was a really great talk, and it's great to bring up the times back in the late '90s. Training and all the great people that we were able to learn such wonderful ways of taking care of patients, and the work that you've done to advance that, since you finished your training has been terrific, as I know from working with you more now. I thought the valve, the TAVR, and patient DNR thing was really relevant, for us at Yale and Bridgeport, because, it came up that patients, could not be, I had a not so widely held view that patients coming to the cath lab could not be DNR. And there was a lot of opposition to that. Because of the reasons that you so eloquently stated, it's like you have to have discussions with patients and talk to them and figure out all of these things. But it's like people are like ordering a cath, like they're ordering, off a menu and, in Epic, without the consideration that's necessary. And that was a real big exercise for us. I'm sure did it settle out that kind of policy is there, like at University of Washington?
Yeah, that's I probably shouldn't throw our people under the bus too much, but we have the policy, but I don't think it's followed, to be honest.
Yeah.
But yes, the policy is that you're really supposed to have that discussion and really
Right.
explore the thing with the patient. I should mention that Ed is actually on the ACC Ethics and Compliance Committee with Sarah and I, and Ed, it's been so refreshing to have you bring your perspectives on that, and it's you're consistently incredibly practical with that, and I so appreciate that.
Well, yeah, thanks so much. It's been a wonderful experience, and working with so many great people. But I think this is a really important part, and the humanism and that kind of thing is an incredibly important part of the training that we provide for the fellows and in our collegial interactions. And it's somewhat lost. With the AI, in regards to the AI, I've worked on a bunch of these care signature pathways that we have at Yale. I think Steve Posick has been heading that up, who you probably know from training. And that to me seems like that's going to be the pathway that the AI will follow. But we have a lot of trouble with people, deviating from the pathways, and they all need to be interpreted, and everything is different going into it. So it'll be interesting to see how it settles out, with the programming.
Yeah, absolutely.
But
that was a wonderful, wonderful talk. Welcome back. About the AI, I think we're always hoping to get these binary answers, that it's yes or no. And much of what you discussed today isn't a binary decision. There are things like empathy and compassion that go into those discussions or decisions. And so I wonder, I guess I'll ask a little bit of a cynical question. Do you think that you can teach empathy and compassion?
I think that we can give people some tools for it to be generated within themselves. I don't think we could stand up and, despite what I'm doing right now, lecture about it and have that really sink into people. I think it has to be an experiential learning. Yeah, I totally agree with you there.
Thanks.
That was a great talk. Thank you. So a little bit a different aspect of the same issue: toolboxes, imaging, ethics, Yale New Haven Hospital, ACC. And then they're investing in specific toolboxes, and we're using those toolboxes. Where is the line drawn here?
Yeah. Ethics is a hard sell, I can tell you, to try to get people to not only fund it, but I'll even allow you to do it when you can be doing so many RVU generating activities. I've actually been really blessed to have people recognize the importance of it, even if it wasn't understanding. So maybe they didn't have empathy, but they were able to do that. But yes, where do you actually, how do you resource all of these things? I think that's a good one.
But also ACES is investing in a specific toolbox.
Oh, I see
Yale-
the issue.
Yale New
Yes.
Haven is investing in a specific
Yeah.
toolbox.
Yeah.
And we are sort of belong to both, and you did in the past. So isn't it unethical?
I think it depends on how people take it and what is sort of behind it. So I think that there are ways to integrate ethical principles into all of those investments that come in there. And mostly what that means is saying, let's stop and think about what the implications of this are. And then I think toolboxes can be very, very important, but unless you go through that exercise, I think you do run into some trouble with unintended consequences, let's say.
Hang on one second. I'm just going to give you the microphone. Just so people on Zoom can hear it.
I talk a lot of term. But you're kind of trying to kind of convey the value to people. It also depends on with what intention everybody entered medicine.
Yes.
Some of us came for patient care and helping patients. Some of them because of the safety of the job and security. Some of them for relative income. So there are obstacles to how actually you can train them. You can kind of make them become more empathic, or is that something you can overcome?
I think it complicates appealing to one's original instincts. I think a lot of us assume, well, why is it that you went into medicine to begin with? Let's try to fan that flame. And you're right, that's a poor assumption because many people went in for different reasons. I think we can set an expectation that what we are doing should be done, and it may not be empathy or compassion necessarily towards patients if one is not really having a lot of interactions with patients. I think you can still say what work you're doing is going to impact patients, even work of discovery. But even just sort of the way that we treat each other within the setting and trying to have empathy with our coworkers should be an expectation, I think, of what we're doing in medicine. And so, but I agree. I think we have to be very careful about some of the assumptions that we make. And well, Eric is here, so I can't talk too much about that. But I know you're exactly right. And how do we construct systems that allow for empathy? How do we construct systems that even reward some of those behaviors that we really want to reward, but often get lost if we just say that they're wonderful, but don't actually back it up with some ways? Don't ask me how to do that. I'm fortunately not in that position. But
Are there other questions? I may comment a little bit on that while other people are thinking of questions, which is, I think that's a kind of a core issue of, and something else Jim and I are working on now is, a project on really kind of delving into what professionalism actually means, and this idea of, there's certain professional expectations, and there's maybe what motivated you, but being a professional is not just about what you want to do, but what your duty is by virtue of your choosing to enter this profession. And there are certain standards that we argue need to be adhered to, and whether that's from an Aristotelian virtue ethics sense, you do this because that is part of your character, and that is sort of an innate virtue that you have, or a virtue that you've cultivated, or whether from a more Kantian perspective of viewing things through the frame of the categorical imperative and your duties and obligations by virtue of being a professional, and you may come to that through different lenses, and I think ethics can help us to understand how that happens. But I think that having these conversations is really important to think about how, as we evolve as a profession, we're going to continue to self-define and more importantly, self-regulate, because, and this is another crux of what we've been working on, the medical profession has evolved quite a bit in terms of how we're perceived and how we perceive ourselves over the past, let's say 50 to 70 years. And So I think that's, there is a lot of work to be done there. And I think in terms of, I don't think that you can teach empathy per se, but I do think that you, to your point, I think that compassion is something that even you can't teach people to feel things that they don't feel, but you can equip people with the tools to provide emotional support when it's needed. And so, Aristotle might say that it's ideal to try to feel these things in your heart of hearts. But again, Kant might say, well, as long as you're providing the adequate support to the patient, you're discharging your duty. That's the most important thing. And we can argue about that. But ultimately both of those things get down to, one of our, most important professional roles or duties, which is caring for the patient.
Absolutely. And just to throw another ethical argument in or perspective on there is utilitarianism. I think a lot of times there's been a greater emphasis on our duty to society, making decisions even at the bedside that are for the good of society, but that does put us in conflict in many cases with the good of the individual patient. Where do we draw that line? What is our professional responsibility in each of those different spheres? I would argue that what we need to do is sit down and hash this out during training and afterwards, and that will stand us in good stead.
May I say a word? Can I be heard?
Yes, of course.
Thank you, Dr. Kirkpatrick. Thank you so much for a brilliant dissertation and lecture. And I would just like to point out, and I'm sure that you know, that your lecture is being given in the Paul B. Beeson Amphitheater. And Paul B. Bruce Beeson was chair of medicine at Yale for many years, but he was also in 1974, Beeson became the VA Distinguished Professor of Medicine at Seattle's University of Washington Medical School, retiring in 1981. And so that was not to be confused with any other medical school, as you pointed out in your first few comments.
That is exactly right. And his influence definitely lives on there as well as it does in many other places. And he actually hired Howard Spiro, apparently, and is responsible for so much amazing work in this field and elsewhere.
All right. Thanks, everyone. Thank you, Dr. Kirkpatrick.
Oh, thanks so much. It's great to see you too. Yeah, thank you so much.
Great. Thank you.
Thank you.